So again, hello to the group that has previously been part of my presentations. Welcome again. It's very exciting to be able to instill some knowledge and experience of the things that we do on a daily basis. As part of the virtual neuroendovascular OR this week, what I'm going to be showing you are some cases that we actually did this week. I'm going to show specifically 4 cases in which we show the diversity of the patients that we take care of, as well as the team approach that we work in our environment. So let me share my screen. Okay. So again, for the people that don't know me, I'm Dr. Ortiz. I am the Chief of Neuroendovascular Surgery and Interventional Neuroradiology at Lenox Hill Hospital and several other hospitals within Northwest Health. I'm based at Lenox Hill in the city. And what I do, what I perform, I treat any type of vascular, meaning artery or vein, vascular pathology or problem anywhere in the brain, head, neck, and spinal cord. And I do that in adults and children. So what I do is I navigate catheters from the arteries of the leg, the femoral arteries, and navigate inside the arteries of the body, go to wherever the problem is, and then fix it. If it's an artery or a connection between artery and vein that should not exist, I close it, I block it, and that's called embolization. And if it is a blockage that should be open, like say in a stroke, we do what's called mechanical thrombectomy and open that artery. So basically, I'm the plumber of the brain. My Twitter handle and my LinkedIn address, so in case you guys want to connect, to reach out to ask questions, stay in touch, ask for advice, or share experiences. And these are some of the Twitter handles that we're using to promote this program and what we're doing. Cure sometimes, treat often, comfort always. Hippocrates. First case, 88 years old woman, so older lady, history of asymptomatic extraaxial tumor diagnosed in 2005 and followed conservatively since then. This means that she was found to have this mass or tumor. Remember, tumor doesn't necessarily mean cancer. Some people think that a tumor has a connotation of cancer, but neoplasia or neoplasm, that's cancer. A tumor is any growth. And she was found to have this in 2005, and after some workup, it was decided that appeared to be a benign mass. It was extraaxial, meaning outside the brain. So it was not causing any symptoms to her. It was just found because she did have a little bump in the back of the head. And the doctors that saw her at the time thought that it was better just to watch it. Reasons why someone would decide on that would be the person's age. She's 88 now, so back then she was 73. So the surgeon that saw her thought that she was already older and that any treatment was riskier than the benefit of leaving it alone. And so they kept checking on it, and for a very long period of time, it remained stable in size. In these past 12 months, it has grown tremendously. And I'm going to show you pictures of this. So you can see she has this is an axial view of an MRI. So this is slices of an MRI going like this. This is what's called axial. And this is a sagittal view. So slices like this. And this is the back of the head, forehead, right side of the brain, left side of the brain. An easy way to interpret an MRI, draw a line in the middle. What you see on one side, you should see on the other. And here we see something that it looks different, that you don't see on the other side. So that's the mass, and we say it's extra-axial because it's not in the brain per se, this is the brain. So it's pushing on the brain, but it's outside the brain. And as you can see, this is the bone here, this is the bone here, and that's the reason why they could feel a bump in her scalp, because it's outside the bone. Some of it is inside the bone, some of it outside the bone. And looking from the side, the same thing. This is the mass, that's her scalp, this is her bone. So this must have been something that was disrupting bone. And she had this an MRI with contrast, suggesting that maybe it was a meningioma potentially, which is a tumor that comes off the meninges. This is an MRI with contrast. The meninges are the white lining, but impossible to tell unless you do a biopsy and do surgery. At that time, it was decided that she didn't need surgery. And you could see back, the first scan that I showed you was from 2005. This is now 2019. Actually, the first one that I showed you, 2014, this is 2019. And you're gonna see now how it changed. This is 2020. So this is like an explosion of the tumor. Look at the huge mass now. Before it was just this. Look now, some of it is now going into the brain. This is swelling in the brain, like I told you before, draw a line in the middle. What you see on one side, you see on the other. There's a mass inside the brain. There's swelling in the brain. And then look at this. It's all coming outside. It's as if she has two heads. Look at on the side. This is a sagittal view. Look at this. Look at this massive tumor. So they came to us and we decided that we could do a team approach to address this. In order to resect this or to take it out completely, we needed to do whatever was safer for her. And in that case was to do an angiogram, an embolization before the resection. A resection for such a large mass is obviously complex, not just because of the size, but also because she was having a lot of oozing of blood and bleeding from the mass. And whenever they were moving her, she would get an ulceration, an injury to the scalp, and would have tremendous amount of bleeding. So we decided to bring her to the angiography suite. And this is her mass. This is what she's already intubated, ready for our angiogram and embolization, for our procedure. You could see that these are in the back of the head. These are the areas that from where she was bleeding from. And these are very unusual positions for us to work in. Angiograms, I told you, we navigate the catheter from the leg, and typically the head is completely straight so that we understand the landmarks. Now her head is completely rotated, and it's a completely different orientation in what we do. This is the angiogram. This is a lateral view. We were here in the right carotid artery. This is the right internal carotid artery that goes to the brain. And this is the right external carotid artery that goes to the branches that supply scalp, face, and dura, the coverings of the brain. This is the occipital artery that is supplying a lot of the tumor in the back. This is the superficial temporal artery. And then she also has a middle meningeal artery that is going here. That was her original tumor. So she has three major arteries that are supplying the mass. We went into two of them, the two that we could go in safely. This is the middle meningeal artery. This is the injection of contrast. This is how the arteries to the tumor look like in a lateral view. The top of the head is here, the back is here, her nose is around here. And this is the occipital artery, the other one that goes towards the back of the head. Is the entire tumor is here. Our catheter is here. And remember, the catheters are completely straight. And these arteries are not straight, they're tortuous. So we had to use what's called a triaxial system, in which we use a small sheath, a small catheter that we put in the leg, another one that goes from the leg all the way to the neck, another one that goes from the neck all the way to the skull base, and another one that goes from the skull base all the way into the arteries of the tumor. And when we get there, we take these pictures to create the map, and then we embolize it with something called embospheres. Embospheres are basically tiny, tiny, tiny pieces of plastic, to put it in simple terms. And you could see the precipitation of those particles, of those embospheres. They're submerged into some saline that we take out that saline from that syringe, and then we put contrast so that it mixes with the embospheres, so that when we inject it under X-ray, we can see where that particle is going. We're as good as what we can see when we do our job. And obviously, it is necessary for us to create some contrast to the images. And since we're working with X-ray, we need to use the same type of contrast that is used for a CAT scan. You can see that each of these little particles measures 100 to 300 micrometers. So these are very, very, very tiny particles that penetrate very well into the smaller vessels. So you can see that at the beginning of the procedure, this is the injection of the right external carotid artery, the one that supplies all those arteries that we embolize. This at the beginning and this at the end of the procedure. So we were able to eliminate this entire blood flow as well as this entire blood flow. Everything here now does not have a significant blood flow, and this is all to make the surgery and resection safer, so that she doesn't have significant amount of bleeding, so that at the time of surgery, there's better visualization of the normal structures, the nerves, the brain, the normal arteries, the normal veins. Then we went to the left side, same story. This is the artery that goes to the brain, the internal carotid artery. And then these are the arteries that supply the scalp and the tumor. You have the occipital artery, you have the superficial temporal artery, and you also have a middle meningeal artery that also goes to the tumor. And we went into each of them. This is the superficial temporal artery, this is the occipital artery, and this is the middle meningeal artery, and we close all of them. And you see how at the beginning you had all of this blood supply, and at the end, we eliminated the blood supply to that region. So she went to surgery, and this is her CAT scan after surgery. This procedure, the embolization was done on Monday, and the surgery was done on Tuesday. She had some arrhythmias during surgery because she had some blood loss, but not near to the amount of blood loss she would have had if she didn't undergo embolization. And she recovered great. I mean, just looking at this CAT scan, you can tell that the mass is completely out. There's still some tumor inside the brain. She's 88, so that means that we don't want to overdo it. If we take out too much, we cannot put it back, and then she can have a significant complication. So this is a great result for her. Another case from this week, this is a 66-year-old man. He has history of diabetes, hypertension, hyperlipidemia, high cholesterol, high blood pressure, and diabetes. Each of these three factors predisposes people to an increased risk of having a stroke or a blockage of an artery that takes blood to the brain. So each of them by itself. So when you have someone that has all three risk factors, they're definitely increased risk of having a stroke. And this gentleman had a sudden onset of left side weakness and slurred speech. The sudden onset part is critical because whenever people have neurological symptoms, the history of how quickly they came is critical to determine what is the problem, what caused the symptoms. When someone is having progressive weakness, something that is getting weaker and weaker over months and years, that's not a stroke. That's something like a tumor or something else that is growing and pressing on structures in the brain. If whenever we hear the sudden onset that the person can remember what they were doing when those symptoms started, that's typically a stroke. and could be something else, but we need to rule out stroke first, because that's something that we can fix in order to prevent further damage to the brain. Every minute someone is suffering from a stroke, every minute 2 million neurons are dying. So that's why it's so critical that someone that is having stroke symptoms needs to go to the, call 911 and go to the emergency room right away. You cannot make the mistake of just waiting at home. Actually, this gentleman did make the mistake. He said that he was having the symptoms and went to sleep to see if they got better. And he woke up the next day and they were still there. So by the time he came to the hospital, he was not a candidate for one of the emergency procedures that we can perform, whether it is giving a medication through the vein called TPA, which is a clot-busting drug, or doing what's called a mechanical thrombectomy, which is navigating the catheter, going to the artery that is blocked, and reopening the artery to regain the normal blood flow to the brain. He came here too late in order to be a candidate for those. However, we needed to do a complete workup to determine, number one, is it a stroke, yes or no? Number two, if it is, what caused it? Because if we know the cause, then we need to address and tailor the treatment, whether it is medications, surgery, endovascular procedures, or a combination of the above. This is MRI of the brain. This is what's called a diffusion weighted image, which is one in which we can identify the stroke the easiest. Each modality of an MRI shows a different, it's called a sequence. Each sequence shows, is good for different reasons. Some are good for swelling, like the one I was showing you before with the tumor. Some are good to look at blood. Some are good to look at tumors. And this specific one is good to look for acute strokes, strokes that have happened within the past 24 to 48 hours. And actually it shows the evidence of the stroke up to 2-3 weeks after the stroke. And what you see here, and again, draw a line in the middle. What you see on one side, you should see on the other. Here you're seeing something that you're not seeing there. Draw a line in the middle. Here you're seeing something that you're not seeing here. So these white circles, these white dots, those are small strokes that happen on the right side of the brain. Then on top of that, we did what's called a CTA, which is a CAT scan with contrast, and a CT perfusion. A CTA, it is a CAT scan, so it's based on X-ray, different from an MRI. The MRI does not have radiation, it's a magnet that gives you images depending on the fluids in the brain that you're studying. In a CAT scan, in here you're giving contrast, so now you're seeing any arteries are going to look white. And this is the left side. This is looking at him from the front. So left side is here, right side is here. The left is the normal side. The right, you see that there's a blockage. You don't see the continuation of this vessel. And here, in the CT perfusion, on the left of the image, we have what's already a completed infarct that is irreversible. And on the right side, you have what's at risk of having a completed infarct. So right now, he still doesn't have a large stroke, but he's at risk of having a large stroke. And he's at risk of having 88 milliliters or cc's of brain infarcted that would be something irreversible. So he's someone that needs some type of intervention. And as I told you before, because of the timing that he arrived and mild symptoms, he was not that symptomatic. He had some slurred speech and some weakness, but he was not completely paralyzed, obtunded, comatose, with eyes looking to one side of the, without the ability to look to the other side. Those are severe large strokes that need emergency treatment. Someone that has mild stroke and that shows up late, is better to wait a little bit longer, do the entire workup, and then determine what's the best treatment for him or her. As part of the workup, we did what's called an MRA NOVA, which is a study based on MRI technology, but quantifies the amount of blood flow going through each artery. And you could see in the normal side, the left middle cerebral artery has 177 cc's of blood per minute, milliliter per minute, On the right side, they couldn't quantify anything because it's completely blocked. However, there's a reason why he's doing okay, that he's tolerating this blockage is because he has collateral circulation, arteries from other parts of the brain that are compensating for the blockage that he has. And in this case, he has an anterior cerebral artery on the right that you can see has 86 cc's compared to 29 cc's on the left. So obviously, this left anterior cerebral artery is trying to compensate on the right side, and the right posterior cerebral artery, PCA, has 20 cc's extra compared to the left. So you know that 20 plus another 60 has approximately 80 cc's of blood going to the right MCA that are extra different from what the left side is supplying, suggesting that 80 cc's are going to this territory, which is still significantly lower than normal, because the normal side, he had 177. As part of the workup, we also perform what's called a brain SPECT scan. And we do it with Diamox and without Diamox. Diamox is a medication that causes vasodilation. We know that without Diamox, you can see this is a nuclear medicine test. So you can see that the metabolic rate on the right side is decreased compared to the left just by looking at the colors. You can see that this is darker than this. When we give Diamox, it vasodilates the artery. So it means that that medication is given through the vein when it goes through the entire circulation of the body, but when it goes to the brain, it's going to dilate the normal arteries to the maximum diameter. Any artery is going to be dilated to the maximum diameter. What we're seeing here is that, yes, this looks brighter than here after Diamox, so the good side looks brighter, but now look at the difference between the left and the right with the Diamox. How much darker it appears to be on the right side of the brain compared to the left. Why? Because it means that despite the Diamox, this was already vasodilated. The right side was already working at its maximum capacity to give extra blood flow to that right side of the brain that was suffering because of the blockage of the middle cerebral artery. So it means that if this person has any change in blood pressure, meaning dropping blood pressure, any dehydration, gets sick for whatever reason, and defenses of his body are low, then he's at major risk of having a very large stroke on the right side of the brain. We put all this information together to determine if the patient is a candidate for what's called a bypass revascularization surgery, which is basically connecting an artery that goes, in this case, to the scalp. The superficial temporal artery is an artery that if you feel you can feel your pulse in front of your ear, that's its STA pulsating. Superficial temporal artery, a hole is drilled on the skull, and then that artery is connected with the middle cerebral artery, the artery that has the blockage, to give extra blood flow to that right side of the brain. Putting together the fact that he had a stroke, the fact that the flow is decreased, the fact that the artery is blocked, and that this SPECT shows significant abnormality, he's a candidate for a bypass. All of them have to be together. If a bypass gets done without all this information, then you're at risk of a surgery that it was not necessary. Meaning, even if the artery is closed, if the collaterals are not enough to sustain, and this brain SPECT doesn't show this complete abnormality, when the artery gets connected, it's not going to work, because the body's smarter than any of us, and than any intervention, than any device, than any surgery. And the body's going to say, I have enough blood, I don't need extra. And you can do a beautiful surgery, spend 12 hours doing the perfect operation, and it's going to fail. So that's why patient selection is so critical. As part of the workup in preparation for the bypass, we perform an angiogram. This is an AP view. We're looking at him from the front here. We're looking at him from the side here. You can sort of make out his left orbit, right orbit. So this is the right internal carotid artery. This is the contrast going inside the artery. And here's the blockage. You see this, the flow continues normal to pacify in the anterior cerebral artery. And these, you see these fine arteries? Those are the PL collaterals. Those are the collaterals that are connecting this ACA to the MCA. This artery is supposed to come from here, but it's coming all the way around because of the blockage down here. So that confirms what we had seen on the CTA and MRA. And number two, the other critical part of this angiogram is to look for the donor vessel, the artery that is going to be connected to one of these branches of the MCA. And as I mentioned before, is the STA, superficial temporal artery, that in most people is one branch that divides into two. In his case, he was born with two different origins. One branch is here, the other branch is here, but one origin is here from the external carotid artery, and the other origin is lower down. So in his case, this branch is going in front of the ear, like most of us. This one is going behind the ear, which is important so that when the surgery gets done, the artery can be found easier while following with the Doppler, with ultrasound. And so the surgery was done, and this is the angiogram in the surgery. This was from yesterday. This is an AP view, lateral view. Obviously, the quality of the picture is not as good as what you saw in the previous picture because an angiogram in the operating room doing an open surgery is not the same machine. That doesn't have the same specificity and sensitivity as the other machine. But you can see here, this is the artery that was going towards behind the ear. This is the one that was going in front of the ear. And this one that was going behind the ear, that was the one that was connected. You can see it coming around and connected here with the middle cerebral artery, whoops, which supplies blood flow both ways, this way and this way. And you can see in the AP view, the same thing. The artery is connected here and supplying blood all the way down, all the way down, all the way down to the middle cerebral artery bifurcation. So this is a great result for a bypass. Again, it's still 24 hours after his surgery. So he's still recovering from it, but we expect that he's now protected to prevent a stroke from happening again in the future. Another case, this is a 41 years old man. This is another case from yesterday. History of seizures in 2006. So he was very young when he started having convulsions. At that time, they were looking to see why he had seizures. Seizures are basically abnormal electrical activity in the brain. And it's hyperexcitability of the brain, different from a stroke. In a stroke, you have negative symptoms, meaning that you have paralysis. You cannot see, you cannot speak. In a seizure, you have hyperexcitability. So the patient is shaking, is doing more than expected. Sometimes he's just seeing things, sometimes just hearing noises, smelling things. Seizures can present in many different ways depending on the part of the brain that is being affected. In his case, it had to do with affecting shaking on the right side of the body, and it also affected his language as well whenever he was having a seizure. Because the AVM was in a dominant hemisphere, the left side of the brain in most people, especially all of the right-handed people, the left side of the brain is the dominant hemisphere, meaning the one that controls language. So whenever some problem gets found on the left side of the brain, the left frontal lobe, we need to outweigh the risks and benefits of doing a treatment to that problem, that left frontal lobe, because you can potentially affect language that could be irreversible. And some people can end up without the ability to speak or to understand others, so called aphasia. We were not involved in his case at that time, but it does make sense that they were concerned with treating him, treating this AVM just because of the location. So treatment for AVMs can be, you could leave it alone, but it has a risk of bleeding in the brain if you leave it alone. 2, you can do surgery, take it out completely. 3, you can do an embolization, which is, like I mentioned before, going through the arteries and disconnecting the arteries from the veins. Or you can do a combination of those treatments. And each of them has pros and cons, like anything in life. Nothing is risk-free. And we need to weigh the risks and benefits of all of them. At the time, the group of doctors taking care of him decided that the best thing for him was radiation. And the rationale for why people would treat with radiation is because you don't need to do a craniotomy. So it's supposed to decrease the risk of having injury to the brain. The embolizations carry risk, and it's very challenging to cure a large AVM with just embolization. Small AVMs you can cure with just embolization safely, but large AVMs are more challenging, they're riskier. So they decided to treat with radiation. They did it twice. Radiation, different from the other treatments, when you treat with surgery or embolization, the AVM gets cured right away. With radiation, it takes 2 to 3 years for the radiation to have its effect. So they treated in 2006, they saw that it didn't go away, they treated again in 2010. This is how the AVM looked initially in 2000. This was, I think, 2008. This is the AVM. This is the abnormal connection between arteries and veins. This was called the nidus. This is another view of the same thing. This is an oblique view and this is a lateral view. His eye is around here, top of the head, back of the head. His neck is here. This is an oblique view, so the head is rotating. Is challenging to know the specific landmarks, but this is easier here because it's lateral view. So this is a nidus. You have arteries going into the nidus and connected to veins that are draining the nidus. These are congenital lesions. People are born with this, or they get formed very early in life, a few days, weeks, months of life. They don't form later in life. This was called a PL AVM, PL arteriovenous malformation, meaning of the brain parenchyma itself. And the reason why they increase the risk of bleeding is because normally you have arteries that carry blood with pressure. You feel a pulse in your arteries. In the veins, you touch them, you don't feel a pulse. It's because in between arteries and veins, there are capillaries that dissipate that pressure in the middle. In an AVM, you have arteries connected with veins directly. So now the pressure of the artery is going directly into a vein that is not made to sustain that pressure. And then the veins get larger and can bleed. These are all dilated veins. These are dilated vein, dilated vein, dilated vein. These are the arteries going into it. So they did the radiation, as I told you twice, and he got worse from his seizures. He got worse from his symptoms. He developed weakness on the right side of the body. He developed trouble speaking. And this is an MRI from this year when we met him a couple of months ago. This is the flare sequence of an MRI. And this is an MRI T1 weighted image with contrast. Back of the head is here, forehead is here, right side, left side, right side, left side, right side, left side. This is the area of AVM, and all of this is swelling. That's swelling from radiation necrosis, injury to the brain from the radiation, from the amount of radiation he received. All of this here, this appears to be injury to the brain from radiation. So despite the fact that the radiation was performed with the expectation that it was a safer option than surgery, obviously in his case, for this specific AVM in this location and the amount of radiation that he received, it was too much. So we brought him back to do an angiogram and see what's happening with the AVM. And what has happened with the AVM is that it has significantly reduced. You don't see the big ball, the big nidus that you saw before. However, there's still AVM here. And how do I know that? Because when we inject contrast, it's supposed to go to the arteries first, then to the capillaries, and then to the veins. So you're supposed to see in one picture only arteries, in one picture only capillaries, in one picture only veins. Here, I'm seeing arteries. These are all arteries, 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 arteries. These are arteries. These are an artery that is dysplastic from the radiation changes. And This here, that's a vein. This tiny thing here, that's a vein. This is a vein. So we have an artery connected to a vein. So even though it's much smaller, he's still at risk of bleeding. Unless an AVM is 100% cured, the person is at risk of bleeding. So partial treatment for an AVM is not indicated. We don't know if partially treating an AVM, you're decreasing or increasing the risk of bleeding. We don't know. We have in science, we haven't been able to document that. But we know it's not cured. We know that there's still a risk of bleeding. So we decided to go ahead and do embolization. And this is what we do. This is the catheter that came from the leg, is now parked at this artery, this bend is behind the eye on the left side. So this is behind the eye, and then we keep going up, 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 up. This is injecting in the middle cerebral artery. This is the artery going like this, going like this. This is normal. This is normal here. All of this is normal. This is normal. What is abnormal is seeing this vein here. So we went from here into this tiny, tiny vessel, this connection. This is what's connecting this artery to this vein. And then the next picture is when we got there. You see this position of the catheter is right here. So now we're injecting contrast, and we see that now we're in a safe position for us to inject the embolic agent to disconnect the artery from the vein. In this case, we use N-butyl cyanoacrylate, NBCA. This is basically crazy glue. Just like the crazy glue you can buy in Home Depot, this is the same thing, but cleaner and obviously more expensive. Because in order to make it a medical device, actually each of these vials that you see here, each of them is $2,500. So super expensive. And that's a big problem with healthcare. As you all know, that's an issue that we have been attempting as a society to address for decades, and we're nowhere near. The prices of medications are too steep. The prices of devices, of implantables, of any treatment that we utilize in the hospital or take at home is too expensive. It's something that maybe with many of you listening today will be interested in tackling this issue, because it will definitely help our society in decades to come. But this is medical crazy glue, and what we do is that we inject it through the microcatheter. We mix it with something called ethiolol, which is an alcohol-based substance that is radio opaque, so you can see it under X-ray. It creates contrast because the glue you cannot see under X-ray, so you need to be able to mix it with something so you can see under X-ray. In his specific case, because it was such a small vessel, we also added something called tantalum, which is a metal powder, and we inject that through the catheter, watch it going into the vessel that we want it to go, and immediately that we achieve our goal, we pull the catheter out before it gets stuck to the artery in the brain. And just like crazy glue, it works that quickly. So we typically have from 2 to 4 seconds at the most to be able to inject this from the leg all the way to the brain. 2 to 4 seconds. So we work in teams so that we inject it and the other person pulls it right away. So after that glue, we went for another feeder. The other one was here. So it got disconnected. Now is a second one from here, going like this. You can see when we make that turn is here, the catheter is here, which is right here. And this is how it looks. This is how the catheter looks under contrast. And we inject the glue. You can see here, the tip of the catheter, this is the glue inside that vein, in the connection between the artery and the vein. And this is how the catheter looks while we're injecting, and this after we pulled out. You see it looks like a white dot instead of looking dark, and this white line instead of looking dark, because here it had the glue inside, and this after we pulled it out. And these are final results. So that vein that we were seeing before is not there anymore. So he's cured from the AVM, and right now he's in the operating room to have that those necrosis, those little cysts that you saw being resected, with the expectation that his seizures are going to be better controlled, and that his swelling is going to come down, and by the swelling coming down, also his language and strength is going to improve. That's the hope and expectation. And one last case I'm going to show you is a 3-year-old boy that we treated this week. He was found to have a mass in the right ear. It was interesting because even though, yes, they found a mass, it was really like a polyp. But associated with the polyp, he did have something underneath that required surgery to take it out. But in 2 separate instances, whenever they attempted to take it out, it bled so much that they had to stop, and they couldn't get any tissue to know if this is cancerous or not. This is the boy's MRI, and this is T2 weighted image, and this is a T1 with contrast. Back of the head is his teeth, back of the head, his teeth, and this is the right ear, left ear. So obviously you see something on the right that you don't see on the left, and all of this is abnormal. This white, and with contrast, this white is abnormal. So when we see things like this, it could be a benign tumor, like a hemangioma, a benign tumor like a hemangioendothelioma, or it could be something more malignant. But unless you do a biopsy, you don't know. In some people, they can also present like this with something called an AVM of the ear, a vascular malformation of the ear. So after the 2 failed surgeries, he came to us for us to do an angiogram. And this is his angiogram. This is looking at him from the side. The back of the head is here, top of the head. His forehead is here. The catheter is here. And we're injecting lateral view, the external carotid artery. This is the occipital artery that goes to the back of the head, external carotid. And you see this, that's a tumor blush. That's abnormal, as you can see compared to the rest of the picture. That's completely abnormal, and that means that there are many arteries going there, and that's what's predisposing the bleeding. So we went into each of these arteries, this one, and this one, all the arteries in the vicinity, to understand what's supplying the tumor. We went into the superficial temporal artery that wasn't really that vascular. We went to the middle meningeal artery. This is normal. Actually, this artery here is a petrosal branch of the middle meningeal artery. It supplies the facial nerve. So if this artery gets blocked, either by disease or by a procedure, then the person will have irreversible facial paralysis. So that's something that we need to pay very close attention to. This artery here is another critical one. This is a collateral, meaning an artery. Remember, we're outside the brain here, but this artery has a collateral to the ophthalmic, to the artery that gives blood flow to the eye. So if that artery gets blocked, it will be irreversible blockage and irreversible vision loss. So we need to pay attention to all these details before we go to the actual tumor. This is how the catheter looks under X-ray, and from there we inject contrast, and this is the tumor blush. So you can see many vessels going into the tumor. They're super thin, tiny vessels. That's why it looks like this blush. It looks different from the cleaner, tiny arteries that are individually identified. So in this case, we injected MBCA, the medical crazy glue, as well. And this is how it looks at the end. So we eliminated that blush that he had, and today he's undergoing surgery to resect the tumor. So again, we work in teams. The strength of the team is each individual member. The strength of each member is a team. This was Phil Jackson's quote, legendary coach for the Chicago Bulls and the LA Lakers, after being a player for the Knicks and winning a championship with the Knicks as a player as well. And like I always like to say, it is critical that we work together. It makes us better. It makes us whole. When doctors, surgeons work by themselves, there are many insecurities because obviously you cannot know everything. And there's so much to learn in medicine that you need to complement each other. You need to work in teams, and you need to work with teams that are so competent that you can trust wholeheartedly and that you can trust in their capacity as a surgeon, as a human, as a friend. And I'm lucky to be in that situation. Thank you for your attention to this presentation. And now we're gonna be open to questions.
I just opened up the chat, so questions should come in.
Okay. Let's see. In the first case, why did they wait for the tumor to grow so big before deciding on surgery? Had the tumor been removed early on, it wouldn't have reached this stage. You're right. And actually, there's a question that many people here in the hospital were asking me. Like and the answer is, like I described, for many years, it was very well controlled. It was a small tumor, and this grew exponentially in the past couple of months. And initially, when they were looking for help, they went to multiple neurosurgeons and in the area, and they were afraid of operating this tumor. This is a very rare tumor. This is something you see once, twice, or 3 times in your lifetime as a neurosurgeon. So it is, I'm not surprised that many people were afraid of operating this. Again, going back to the team, if you have a great tumor surgeon that doesn't have an endovascular partner, he's not going to be able to be as effective. If you have a great endovascular partner that doesn't have a great tumor surgeon, he's not going to be as effective. If that tumor surgeon and endovascular, they don't have a skull-based ENT surgeon that can also help with that case, they're not going to be as effective. If you don't have a vascular open neurosurgeon that is not part of the team, they're not going to be as effective. So that's why every part is so critical. So whenever you end up working in an environment, look to make sure that you can complement each other. Having redundancy is not great because then your uniqueness gets hidden and then you're not utilized to your maximum. But having complementary roles it multiplies the experience for everybody and the good outcome for the patient for sure. You said that Diamox dilates the normal artery. Why is Diamox used to treat the tumor cerebri? Is if the patient has intracranial hypertension, how does the dilation of the artery relieve the pressure? So Diamox for pseudotumor obviously is taken orally, and it is a medication that is given continuously as a standing medication on daily basis, and because of that, it's a diuretic. But when it's given acutely, that effect that you saw the Diamox, that only lasts minutes. So that's the big difference between giving a medication IV high dosages versus some long-standing medicine given orally. What could have gone different for case number 2 if he did not try to sleep off? Okay, so if he would have arrived earlier, he would have been a candidate for mechanical thrombectomy, which is the standard of care for acute ischemic stroke. And we would have navigated a catheter, go straight into the artery, reopen the artery, and his symptoms would have resolved that day or by the day after. He would have not needed a bigger surgery. He would have not required to stay in the hospital so long, and he would have not required long-term follow-up. Now, for lifetime, he will be getting an angiogram in 6 months. He will be getting MRAs every year. So obviously, now things are more complex. He's fortunate, though, because we were able to find the problem and address it to prevent another stroke from happening. Some people, when they go to sleep, they wake up worse or they don't wake up. They die from swelling in the brain from a stroke. Or when they come to the hospital, it's too late to do anything. If the stroke is too big, you cannot even do a bypass because there's nothing to salvage. So that's the main difference of reacting quickly. Can a patient be asymptomatic when having a stroke? If so, how would they know when the right time? Okay. So obviously, if you're, yes, number one, you can be asymptomatic from a stroke. Those are called silent strokes. And number two, obviously that person would not look for medical attention. What happens usually is that after someone has a mini stroke or TIA, they are predisposed to having more frequent events after or bigger events. So it is common that when someone has a silent stroke, they have a bigger stroke later on or a TIA later on. Rarely we find someone that by coincidence was due for a checkup and we were checking, let's say, an ultrasound of the arteries in the neck, which is something very common that we do for people that have predisposing factors and older in age. And we find on the ultrasound that there's narrowing of the carotid artery, and then looking at the brain to see if that narrowing has caused any stroke. We sometimes find silent strokes like that. But it's rare that someone that has a silent stroke is not going to have a major stroke after. Thank you for the comment, Lina. For the first case, why wasn't the tumor resected before? Okay, we answered that. How much of the glue do you typically use? So the amount of glue that we inject is very, very small. Each vial brings 1 cc, 1 milliliter. And that milliliter we dilute it with the ethiol that I mentioned. So usually a typical combination would be 2 milliliters of ethiol to 1 milliliter of the glue. So that's 3 cc's in a vial you have combined. And of those 3 cc's per injection of glue, we don't usually inject more than 0.2 or 0.3 milliliter in the brain. Obviously, some of it is lost in the microcatheter because, as I told you, we look where it is going at the end of the microcatheter, but the dead space of the microcatheter has glue, has the embolic material, which is usually approximately 0.25 milliliters of the embolic material. So it's rare that we use more than a vial. Could the previous professionals who administered the radiation be held accountable since the patient was given too much radiation? It is definitely, yes, a controversial topic. I don't disagree that this is a case in which it is appropriate to investigate further the amount of the radiation and the specific field where the radiation was given. Because yes, if you give too much radiation, you can cause this, or if the radiation is given in the wrong place, you can cause this. So yes, can someone be sued by this? People get sued for many different reasons all the time. Some that are appropriate, some that are not. So it is, yes, appropriate to look into this. I don't know the answer if there was a mistake made or not, just by looking at the MRI. I don't know that. Is MBCA expensive to produce, or is it price inflated, period, end? That's the problem, that the pharmaceutical companies charge too much. Otherwise, people wouldn't be making hundreds of millions of dollars running a company. In the case with the 3-year-old boy, how did they cut off the blood flow to the tumor? It was by the injection of the NBCA. What causes a patient to develop an AVM? Those are just in the formation in utero. It's not specifically anything that a parent can do. In some people, there are, yes, congenital genetic predispositions, people that are born with genetic abnormalities that predispose the formation of AVMs, but many times it's just random. Will it be possible for college freshmen currently to shadow you next summer? The answer is yes. Reach out to us, so we are welcoming people. We typically had approximately 20 to 30 students spending time with us, usually college students that were looking to go into medicine. Hopefully the pandemic is over by then. In the first case, is there a risk of regrowth? Yes, the answer is yes, but given that her age, is unlikely that it will grow to a large size in the upcoming years. For the first case, if the tumor started outside the skull, how did it enter the brain? Remember, it started at the level of the skull. It destroyed the bone. It destroyed the bone. It was growing outside, but there was some part inside the skull, outside the brain. And it's very likely that it became malignant. So we're waiting for the pathology to come back. Let me see what else. Can MBCA be used to limit blood supply to vascular tumors so it can be resected? Yes, we do that many times. My medical journey, oh my God. I don't know if Josh, if I have time for that, or it's already 11 a.m.
If you want to finish with it real quick, or give me a little minute of it, and then we'll call it from there.
Okay, so basically, I was always inspired by my father. He's a doctor in Puerto Rico, retired a couple of years ago, and he was my inspiration and my role model as a kid. Then when I grew up and went into high school, I knew that I liked sciences, and I looked into everything, but I was attracted more to medicine per se, not necessarily biology. My favorite subjects were chemistry and math. When I did an undergrad in microbiology and with a minor in chemistry at the University of Florida. And then I went into medical school thinking that I was going to be an orthopedic surgeon. I like sports. I thought I was going to be attracted to that when I went into orthopedic surgery. The mentor in orthopedic surgery was not great, and that I'm sure had a lot to do with it. I got demoralized about orthopedics, and my favorite subject was neuroanatomy in first year in medical school. And from then on, I started looking into the neurosciences. I went to Thomas Jefferson University Hospital in Philadelphia to do a residency in neurology. When I started doing neurology, I knew I wanted to do more. Neurology is a great, fascinating field, diagnosing, doing research, and giving medication, but there's no procedure. And I found another avenue, which was neuroendovascular surgery. I spent a lot of time with the neurosurgery team at Thomas Jefferson University in Philadelphia with mentor Robert Rosenwasser, who inspired me to become a neuroendovascular surgeon. And by luck and chance and because of things of life, I ended up training with Alex Bernstein, who's the father of the field of neuroendovascular surgery. He's the master and father of what we do. And I was very fortunate to learn a lot from him. He taught me many things about neuroendovascular medicine, neurosciences, life. I stayed with him as his partner for several years, and there I was working with David Langer. We were partners there, and we made a pledge that we were going to be working together forever, and we've been working together for 15 years now. So we came together to Lenox Hill Hospital in 2012 to start a program from zero. Start neurosurgery from zero, neuroendovascular from zero, neurology from zero, neuroradiology from zero. And look now, you guys are listening to us and are learning from us. So obviously we're very proud and very excited about what has been happening here for the past several years. And again, encourage you to follow the path of the passion of medicine. This is a beautiful career. Any field is beautiful. Obviously, in what I do, I'm enamored with neuroendovascular surgery. I'm 100% passionate about the field, and reach out. Let me know if you need some guidance, and I'm always available.